Excellent. All right, guys. Well, let's get started. Um, hey, Dr. Rapoff, we're going to talk about disaster medicine today. We got a kind of an exciting lecture. So if there's questions, pop them up in the chat or, you can ask them live. I'm sure if you have a question, everybody else will probably as well. So feel free, but let's get started. Um, on the topic of disaster medicine, there's a whole bunch of different things here in the St. Louis region that, we have to take into account for. Of course, our role as EMS, scene safety is the first and foremost of all the things that we need to, make sure our people are safe, make sure our teams are safe, make sure all of first responders are appropriately staged, and then, make sure we set up an incident command, of course. In our SEMS model, and we did this back when we worked with SSM as well, we had a lot of discussions about what would be the best triage type process. We, and looking at the numbers, looking at the data, we decided that, there's a lot of, when you do the red, yellow, green, there was a lot of yellows that were kind of mischaracterized either up or down. And when it really came down to it, going with the ramp triage model because that gave um, people the ability to say yay or nay. So it's relatively simple. Can they follow commands and do they have a radial pulse? Are really your two major questions. One thing to consider kind of about the ramp triage type model. You got to make sure that your pediatric patients, especially your 1 to 5 year old patients, those end up going in the red category because those are ones that need to be disposed. Anybody that's had children or been in around 1 to especially 3 year olds, that it's like as a parent they're kind of trying to actively kill themselves. So, especially in these kind of scenarios when you've got a disaster type situation, um, you got to make sure that you appropriately dispose those kids to the pediatric hospitals and eventually reunite them with their parents and or family. So of course, one of the reasons why St. Louis is popular is because we're three rivers meet. The Mississippi River Valley is the largest river set of tributaries in the entire face of the planet, and a lot of it culminates here in the St. Louis region, truthfully. That's why we're a major hub along the Mississippi. This is where a lot of travel went. But in doing so, we're very prone to having major floods. We've had a good number already, the 93 and a couple years back, but we'll continue to. So floods are a little different from a lot of disasters because you got a lot of different things that come into play. Of course, your physical traumas from actually the floodwaters and debris and whatnot. But when you've got floodwaters like that, typically they're containing all kind of bacteria and parasites and whatnot. So contamination is an important part of it. Make sure you avoid down power lines and that kind of stuff. Of course, hypothermia is a significant consideration even in the summertime. You lose 25% your body heat when you're faster when you're wet. So something you can use your advantage for hyperthermia, but
Hmm.
hypothermia is a significant consideration.
Sure.
And then,
That's
of
a good.
course, assess for potential shock and crush type injuries for eventual rhabdo. Next topic is, and I kind of lump together wildfires and house fires. I think we'll have some other talks where we're going to go more specifically into different topics, but I want to do a brief overview of, kind of the things and considerations for these type of situations. Of course, when you have smoke inhalation, you got to consider carbon monoxide poisoning, the multiple different types of burns, your first degree, second degree, third degree type stuff. And then, assess the patient to see if there's soot in the airway. One of the considerations, I wouldn't put any ointments or any ice on burns. Just make sure to wrap them, and they'll be cleaned out and have the appropriate disposition at the hospitals. And then, of course, if you think you do have smoke inhalation and carbon monoxide poisoning, um, that's a time to put on the high flow oxygen, put on non-rebreather, put up as high as it can go. When you have carbon monoxide poisoning, the half-life of carbon monoxide, because it has such a higher affinity for um, your receptors than oxygen, it's like 200x type of affinity. The half-life is about 300 minutes on room air, but it goes down to about 90 minutes when you put them on a non-rebreather. It goes down closer to, if you can hustle them to somewhere that has hyperbarics, closer to like 15-minute half-life. But I think most facilities don't, and in most places, non-rebreather ends up being the major treatment. Like I said, watch for the airways, soot in the mouth, soot in the nose. These are ones that go bad quick. These are ones to aggressively intubate in the field and protect their airway. So of course, like I said, the major treatments for the carbon monoxide exposure, you got your high flow oxygen, and your hyperbarics. Now, one of the considerations when and a lot of house fires and even manufacturing type fires, you can be exposed to the cyanide. So the
Rivers and fires.
cyano kits that we have now are much improved for what we previously had. The cyano kits that we typically did back in the early aughts and 80s, 90s, those are ones that use sodium nitrite. And these are kits that actually caused methemoglobinemia. So you dropped your affinity for your oxygen carrying capacity, which, it kind of adds insult to injury on somebody that already has some hypoxia and already has carbon monoxide running around, already has, maybe some airway or upper or lower airway trauma. But now the cyano kits are basically hydroxycobalamin, which is, it's expensive, but essentially it's just vitamin B12. A lot of people take that as a supplement just kind of for energy and stuff. So, and it binds as well as the previous kits. So, all right. These guys in. So your first degree, second degree, third degree burns, the easiest way to remember it, if it's just some mild erythema or redness, that's your first degree. Blistering is second degree. And then, if you've got, if it starts to go through the epidermis, that's when you consider it third degree. This is kind of more of a typical third degree. The first degree and the second degree will hurt. Usually, once you get to the third degree, you've gone through the nerves and whatnot, and these are typically, more painless actually than the first two. So we got to talk a little physics, a little science. I know I've talked about this topic, the vehicle car fires, with a lot of folks, but if you're not familiar with our hydrofluoric acid protocols and exposure protocols, this is a good time to start. If you haven't seen a vehicle fire yet, you will. So essentially what happens in the vehicle fires, you've got, let me see if I can write on the screen here. Maybe not. You've got the batteries that contain the lithium hexafluorophosphate. So it's basically a lithium ion, a phosphorus ion, and like six fluoric acid, fluorate ions that are all combined. When that's mixed with water, one of the byproducts is hydrofluoric acid. Um, this this can cause inhalation injuries, ingestion injuries. We've already had multiple topical injuries here in the region. We've had to throw away boots. We've had to throw away turnout gear, even from walking in the runoff, and being exposed from the smoke or whatnot. Making sure you decon immediately. Do your 15 to 20 minutes immediate decon, and then start with your eventual treatments. We kind of developed this protocol. One of the things that you worry about is electrolyte imbalance, and specifically hypomagnesemia. So 2 grams of mag is a safe, easy treatment. But depending on their symptoms, you can use all of it's calcium gluconate. The Calgonate is a topical calcium gluconate product, and then you could nebulize calcium gluconate, and you can use infusions of calcium gluconate as well. Um, in the hospitals, they will actually sometimes we can actually do injections around the site itself to kind of wall off the exposure. Earthquakes. So another topic that um, can be a big piece of the puzzle for us here in the Midwest. I don't know if you've heard of the New Madrid fault line, but essentially follows the Mississippi for a lot of purposes, kind of throughout the Midwest here. We haven't had a major earthquake in this region in many, many years. Typically the earthquakes run on specific cycles. Ultimately they're unpredictable, but I think the last major one they've had in this region was a couple hundred years back. This fault line seems to go off of, we only have a couple thousand years worth of data, which is not a whole lot in terms of science. Seems to go off a 400 to 600-ish year cycle. But of course, if you don't train on it, you don't talk about it, it's something that will it'll happen, and a good chance that it's going to happen in our lifetimes, in our careers. Of course, we've had multiple on the West Coast. A lot of the Asian countries have had multiple earthquakes and have to deal with kind of the secondary portions of it. Of course, you get the crush injuries, the building injuries. One of the things that I wanted to kind of point out, and something I learned in training and putting this PowerPoint together, um, the aftershocks. So typically the way they rate the uh, earthquakes themselves, they base it off the Bath scale, which is essentially the energy, but the energy of earthquake goes up logarithmically. So if you have an earthquake it's an 8 on the Richter scale, that's actually 32x what 7 on the Richter scale is. So it goes up significantly, kind of from one level to the next, but also the aftershocks. Typically the aftershocks are usually within about 1 to 1.2 on the Richter scale, less amount of energy, so not quite as much, but still significant. A lot of the aftershocks will typically happen within minutes to an hour or two. So something to consider, if you're in and around a situation, you're going into an unstable building, after the first major earthquake, expect that you are going to have more. That's the typical standard with earthquakes is when you have one, and I know we don't have a lot of experience here in the Midwest with earthquakes, but when you have one, you will typically have multiple aftershocks, in the times coming. So, of course, watch out for gas line ruptures, watch out for fires, building collapses. These are times to stabilize and get out of harm's way as fast as we can. Hyperthermia. So if you caught my last lecture, hyperthermia and hypothermia are two of the largest environmental killers. We're just getting out of the warm weather season, but still something that can be a piece of the puzzle. Usually we teach people you can lose about every 15 minutes, you can use about a liter of fluids when you're in a significant heated environment. There are a lot of things that can make you more prone to having hyperthermia related type injuries and emergencies, being elderly, being on certain, medications, whether it's diuretics or blood pressure medications, a lot of the metabolic, type of pathologies when you consider um, even just diabetes, but a lot of thyroid conditions, toxic thyroid, toxic thyroid type storm and whatnot. There's a lot of things, and there are certain genetic conditions that don't allow people to thermoregulate correctly. So once you get over 107.6 is kind of the magic number. Once you hit over that level, that's when the cells start to have intracellular damage and you start to denature proteins. That's kind of the point of no return. These are patients to be very aggressive with, ice packs in the axilla, ice packs in the groin. Honestly, wet them and get a fan and blow off the air. That's the fastest way to cool external temperatures with the external environment type of thing. One tidbit I kind of wanted to put in on fevers specifically, we kind of think of fevers as a bad thing. It's not necessarily a bad thing. I got two sick kids home right now, both with croup. Typically, I don't even treat fevers until the kids, either they can't sleep or they're not eating. Fever is our own, we had hundreds of thousands of years of evolution in our human history to develop certain ways to fight off infections, one of which is fevers. The fevers will make the body less comfortable for the virus or the bacteria, whatever we're trying to fight off. There's no correlation between elevation of fever temperature and significance of illness. A lot of the older folks that we see that are septic, a lot of times they don't even have a fever because they're older. If you got a car that's got 300,000 miles on it, you just don't quite have the oomph. You don't have quite the immune system to kick up a fever, but rather, it's really like kids with ear infections that I see some of the highest temperatures, 1035, 104, that kind of stuff. Now, something to consider if the kiddo has a history of febrile seizures or, of course, if they're miserable, can't sleep, that kind of stuff, that's the time to, treat the temperature. But again, just kind of a plug on high temperature and elevation. Lightning strikes, one of my favorite environmental disasters. I can't say that I've seen one clinically. I've been, I'm sure, like a lot of people, close to a lightning strike when I was outside on accident before. But one of my favorites, just because this is the only disaster, this is my favorite PIMP question for students and residents. This is the only disaster scenario where you treat the dead first. And the telltale to all of it is if somebody is in cardiac arrest, they typically are, usually it's VFib, VTAC, and a lot of times a shockable rhythm. But if you get hit by lightning and you're fine, you're typically going to be fine. So treat the dead first. Other people will typically be okay. There's one interesting, another tidbit that kind of comes with um, lightning strikes themselves called coronal paralysis. And this causes a temporary paralysis and loss of pulses to the legs, but a lot of times it will resolve on its own with really no treatment. So ACLS, get them dry, get them out of the environment, and early shocking, kind of like a lot of cardiac arrests. Another thing to kind of consider with the lightning strikes too, they can actually have fixed and dilated pupils, but similar to the coronal paralysis that happens of the lower extremities, it can just be a transient effect. So, treat accordingly. Along the lines of electrocution, obviously the lightning strike is a significant high voltage. Want to put a plug in for electrocutions as well. And I get a lot of patients that come in to the emergency department for either the 110 or the 220 outlets. If you've ever replaced outlets or had to work on small appliances, you've probably zapped yourself with one or both of these. It would be incredibly rare, and there's really no documented cases of somebody uh, somebody having death from one of these. We really don't even, there's really no recommendations to do anything when somebody comes in with a 110 or 220 jolt. Essentially, it's kind of along the lines of if you're already fine, you're still going to be fine. I usually do an EKG just for their own purposes, make them feel like I did something. Probably not a horrible idea, but unless you had that exact S on T phenomenon that we've talked about with other kind of scenarios, usually you're okay. Now, once you start to get to the main box, and I will do my own peripheral work on my house. I'll do I'll change out the 110 outlets if necessary. I don't do any main box because this is where Thank you. This is where you get to, it can be anywhere between 2,000 to up to 30,000 volts that can come through your main box, depending on, is it residential or is it a commercial type area? That one can kill you. I'd stay away from that one unless you really know what you're doing. Hypothermia. So coming into the cold weather season, obviously we've had a dip in temperatures recently. So um, something we need to consider. We don't get quite as many hypothermic cold weather type injuries here in the St. Louis region. But we still, still get below freezing temperatures still. I mean, we had actually more snow last year than a lot of northern cities, including Chicago, Minneapolis, Milwaukee, just due to the weather patterns. And we had a slightly colder than normal winter time. So, um, these are patients, you want to get them dry, passive rewarming for the mild hypothermia, especially if they're wet, if they have snow, if it's raining, that kind of stuff. Um, get them dry, get them into a warm environment. They don't typically recommend putting, a lot of things, especially if you're frost nip or frostbite, we'll put it in warm water. Uh, that's the end all be all treatment. But if you're out in the environment, you don't want to rewarm prior to if you're going to have exposure again. So, and then of course you're not dead until you're warm and dead. So these are patients that, I've seen multiple in my career that were in persistent VFib, but hypothermic. So these are patients that, in the ERs, we will do all kind of, putting either bilateral chest tubes and running warm fluid through the chest or warm fluid through the belly, uh, and put warm fluid kind of in any orifice that we can to warm them up. So if they're in VFib VTAC, again they're not dead until they're warm and dead. So those are ones to transport. A little plug on bioterrorism. I think this is kind of an interesting topic. I feel lucky and blessed to live in the Midwest, but unfortunately, there would be a number of ways for any of our global adversaries to affect kind of us on a nationwide level, and one of the major ways would be bioterrorist type of thing. I know we had a little bit of an insight into a global pandemic in the last 5 years and PPEs and whatnot, but I think there are a lot of conditions and things out there that can be used in these type of scenarios. As you can see from the anthrax, the smallpox, the botulism, the plague, most of it, especially for field care, is supportive care, short of, um, in the botulism, that's one that can cause some early respiratory issues. We will typically intubate and have them on a ventilator for a while. But use your PPE. A lot of these are, of course, highly contagious. So making sure scene safety and making sure to keep yourself safe. And then, of course, you've got your chemical agents. Remember, for your nerve agents, you got your sludge acronym. I think I got to slide it on the next slide. But your blister agents, your mustard gases, these are all ones. Make sure you do your decon, prior to transport, prior to even putting them in the rig, so you don't expose yourself. Your blood agents, like your cyanide, and then of course your choking agents, your phosgene and your chlorine and whatnot. Again, decon, scene safety. For your sludge, nerve agent type stuff, remember your sludge, pneumonic, sweating, lacrimation, urination, diarrhea, GI, and MSS. So basically, they've got fluids coming from every orifice and every area. These are ones you want to give your 2-PAM, and you want to continue to give atropine. One of the questions we always give the training residents is, when do you stop giving atropine? And we throw all kind of wild vital signs at them. Respirations are way up, the heart rate's way up. When do you stop giving it? And the answer is when they become dry and they stop putting, fluids, all our internal fluids external. So continue to, use whopping doses of atropine and of course transport to appropriate facility. Radiation exposure, another hot topic I know we have here in the Midwest. These are kind of the good number of Superfund sites we have in the United States. Obviously, a lot on the East Coast, but here in the St. Louis area, we're part of the Manhattan Project, and we have a handful of Superfund sites in the area. As such, you know, when you know you're in and around radiation type situation, the the biggest thing to consider is the distance, the time, and you know these are some of the early type symptoms that you will get from radiation. Nausea, vomiting, headache, diarrhea, fevers. Sometimes you can be altered disturbance. These are the first couple of days. Usually there's an incubation period, a couple of weeks-ish before you start to having, some internal issues, either with your GI tract, your blood cells. You can start sloughing off your epidermal layers, that kind of stuff. And of course, having nerve and blood vessel type injury. So if there is a dirty bomb off fall type of scenario, the big things to consider is time, distance, and shielding. Using the ALARA principle, which is as low as reasonably achievable. Um, these are patients that we may have to consider, especially if we have the ability to use appropriate PPE. We may have to consider life over limb type of situation where you have to treat, prior to doing proper decon. Obviously a lot of the decon protocols recommend 15 to 30 minutes. Usually if you can do a quick decon, especially if you have somebody that's in cardiac arrest or somewhere thereabouts, and you can get 80 to 90% of the contamination off. But again, make sure to protect yourself. And again, remember the ALARA principle: time, distance, and shielding. Explosions, unfortunately, is something else we've seen quite a bit here in the United States. It's happened before, it's going to happen again. Another interesting, type of a scenario that you have to consider all of the different type of injuries that happen with these situations. So you got really 5 different types of injuries that come with it. You got your primary, which is the initial shock wave will happen prior to anything, can cause, uh, pressure in the lungs that can cause pneumothoraces. It can rupture eardrums. The secondary is from flying debris, shrapnel, that kind of stuff. Tertiary is the patient is actually taken and thrown. I don't know if anybody watches Mythbusters, but they did a Mythbuster on this specifically, and it kind of showed the exact right area of the blast wave that you needed to be essentially to get thrown. And it wasn't quite next to the explosion, but it wasn't significantly far, kind of within a number of feet, 5 to 8 to 10-ish, depending on how large the blast is. But, when you get thrown, not only is it when you land, but also when you hit, your internal organs kind of jar inside your body. And then, all of the quaternary is your burns, your crush injuries, psychological trauma, that kind of stuff. And finally, of course, the radiation and the chemical burns that happen on the backside. So a good graphic of the different types of injuries, most of which we really in the field have to kind of deal with the first 4 all at the same time. So, but things to consider, when you have a large blast injury like that. Sometimes it's easy to forget, especially the primary and the tertiary parts, when usually the secondary and the quaternary, if you've got a burn or if you've got a penetrating injury, those typically will present faster and easier than some of the others. So something to consider. So we do live in Tornado Alley here, another consideration here in the Midwest, not quite as much as Texas, Oklahoma, but when you're in the Great Plains, you're at a much higher risk of warm air meeting cold air, and that's kind of how they happen. So you got your flying debris, you got your structural damage, and of course being thrown from the wind itself. Some of the unique dangers that we have to consider, and this is all about seam safety. You know, most of us are fire EMS here in this region, but even if you are just fire, even just EMS, you have to consider the scene safety portions of it. You know, obviously the down power lines and the electrocution risk is there. Of course, your natural gas leaks, and then your unstable structures. Most of the times, you're going to see either penetrating or crush type injuries. Obviously, a lot of times we get the prolonged entrapment and whatnot. So, animals and insects. We'll probably do a little bit longer discussion. I wanted to touch on it here just a bit on this, but we'll probably do another lecture maybe next year, a little bit broader about this topic. I think there's a number of topics in here that we're gonna likely expand upon. But animals and insects is something I wanted to briefly talk about. You know, here in the United States, we really, especially if you heard my last lecture, we really just have overgrown earthworms in terms of the snakes that we have here. You know, our rattlesnakes, copperheads, water moccasins. Yes, they're venomous, but most of the time it's just the kind of local tissue damage. Rarely do they end up with systemic situations. Usually, the way I've seen a good number of these in my career. Most of the time, they're on a hand or a foot. A lot of time, most of the time, we'll admit them to the hospital and kind of monitor. We don't typically even do antivenin unless the symptoms go past the elbow, past the knee, or if they have systemic symptomatology. Usually we just admit them for observation, kind of in case type of thing. It's rare to have you know, a truly serious venomous envenomation here in this region. The most of our hospitals in the periphery do have antivenin, of course. A lot of the big centers do, and the zoo as well will have some antivenin depending on what type of envenomation. Similarly, our spiders here in this country are really not that dangerous. You know, we've really got the black widow and the brown recluse. The black widow will cause a little bit more unified whole body type of issues, muscle cramping, rigidity. Mostly it's supportive care and local, you know, a lot of times we'll put them on antibiotics. The brown recluse is kind of more of a local tissue necrosis type of situation. Most of the time when I have people come in that have abscesses somewhere, they tell me they had a spider bite. Most of the time they're wrong, but the treatment is the same. You know, we treat them both for essentially abscess type stuff, covering, you know, your normal type of your normal abscesses are caused by your normal skin flora, which is your staph, your strep, that kind of stuff. So, um, bees, wasps, and ants are actually more dangerous than the snakes and spiders. If you caught, like I said, if you caught my last lecture, that category of insects is actually the third deadliest here in the United States, and it's of course due to the anaphylaxis. So I had a call about this recently, you know, of a question: should we or shouldn't we give epinephrine in a kid that was having kind of some airway issues? Be aggressive. You know, it's much easier to be aggressive early with epinephrine. You know, the epinephrine is essentially an analog of the adrenaline. You know, it's a naturally occurring hormone that we have in our bodies. So if you give it and you're wrong, it's, you know, they get a little tachycardia, they get a little hypertension, but that's a transient effect. But if you don't give it and you're wrong, then the consequences can be devastating. You know, especially in young kids. You know, the airway, similarly to any pipe, the physics of any piped structure. When you reduce the airway by 50%, it's actually you know, the pi r squared. So it's 4x the amount of circumference shrinkage that you get just because of the way the surface area of a circle essentially works, and the physics of that. You get a significantly lot less air movement and a lot less issues. So times to be aggressive. You know, if you're not sure of any type of mouth, throat, face, airway, trouble breathing, I'm usually pretty aggressive with giving the epinephrine. You know, again, You'd rather do work and treat as much as you can. And then I threw tick bites on here because that's something I get a question on a lot. We do have reported cases of Rocky Mountain spotted fever here in this region and Lyme's disease. Usually, if you get the ticks off within the first 36 hours, it prevents any of that type of transmission. So, shower, spread your toes, check all your backs and cracks and make sure to get them off in a timely fashion, and it's usually not an issue. The tick bites, when you're concerned about Rocky Mountain spotted fever.
17.
Oop, we'll pause a second. You will cause a bullseye type of rash. Those are ones we're a bit more aggressive with. It's like a 3-week treatment of doxycycline. So common antibiotic we use, but can hold off devastating consequences down the line. Acute mountain sickness. I thought this would be a fun topic to throw in here. We're talking about environmental disasters. I like to go to altitude at least once or twice a year. So this is actually a picture in the Gunnison County. The mountain on the left is a picture I took. The mountain on the left is Gothic Mountain, just past Crested Butte there in Gunnison County in kind of south central Colorado. But I often will, the base here is, in this picture is about 10,000 foot. I will often myself get to altitude, and the older I get, the harder I feel like it is. So we like to do a slow ascent. A lot of times stop and maybe 5, 6, 7,000 feet and acclimate for a day and give your body a chance to kind of adjust. Initial symptoms, headache, nausea, fatigue, dizziness. If you've ever been to altitude, you've probably experienced any and all of those symptoms, at least for the first day or two. But where it gets to be serious and where we have significant concerns is when you have the HAPE and the HACE. The high altitude pulmonary edema, essentially they will start to fill up their lungs. The exam is very similar to like a CHF exacerbation. They sound wet, wet, wet. The treatment is the oxygen, and then calcium channel blocker, actually nifedipine, which causes pulmonary vasodilation and improvement of the symptoms. And then HACE, which is even worse, the high altitude cerebral edema. You end up getting swelling on the brain, can cause confusion, loss of coordination, altered mental status, severe headache. Of course, the treatments are oxygen and steroids, dexamethasone. But really, truly, the only definitive treatment of both of these is descent. So, got to get them to lower altitudes. Most of the time, these are things that happen 12,000 feet above. The older we get, the less ability we have to adjust, especially in acute settings. So, it's not uncommon for even elderly folks to have symptomatology when they go to 5, 6,000 feet, where young kids can get to, 12 to 14, no problem in a day. And it kind of goes from there in a sliding scale-ish. Anybody that does snorkeling or scuba diving, I thought this was another interesting topic, and we do have rivers, lakes, and whatnot here in this area. So, not something I see nearly as much as when I was in South Florida, but we do still see obviously drownings and near drownings, but do see some barotrauma from and eardrum rupture from swimming and scuba diving in the region. So decompression sickness, this is a situation where when you go from usually depths, and this is a scuba diving injury, usually depths greater than about 10 meters. So every 10 meters that you go down, that's 33 feet um, every 10 meters you go down, you increase the atmospheric pressure by 1. So you're at sea level, our atmospheric pressure is 1. Here at, in the St. Louis area, we're about 800 to 1,000 feet. So your atmospheric pressure is like 0.9 and change essentially. But as you go underwater, it goes up relatively quick every 10 meters. It's not until you get to depths of about 30 to 40 meters. Once you start getting down to 100+ feet ish, and or you're down for a lot longer, that's when the nitrogen, our air that we breathe is mostly nitrogen, and only about 20% ish oxygen. The nitrogen diffusion within the uh, cells themselves um, will be what causes issue if you have a rapid ascent, or if you're down for too long is what makes you more at a significant risk for the decompression type sickness. So good reason to make sure you have proper training. If you're into scuba diving, make sure you follow your protocols and be safe type of thing. Of course, we don't see marine type injuries in and around this area, but um, if you do see it, if you're on vacation, you do see a jellyfish sting, it's salt water and or vinegar and or urine. So we are going to do a lecture. I think I don't know if it's next month or it's coming up. We're going to do one on kind of TECC and active killers, but I wanted to throw in just a quick plug on this topic, because this is again something that it's not if, it's when. We will see this kind of scenario. Um, you know, so these are dynamic scenes. Things change quickly. We gotta have work with our other first responders, our police, to make sure we stage appropriately. If you caught my talk at Priority One a couple of months back, obviously I'm a huge advocate of tourniquets and making sure we stop the bleed. The limb exsanguination is the most common cause of preventable death in a lot of these type of trauma scenarios. So be aggressive with tourniquets, be aggressive with you know stopping the bleed and treating wounds and whatnot. And then of course rapid extrication. Um, you usually, for the for our folks' purposes, unless you are part of a Tim's team, part of a SWAT team, the majority of the time we should be in this cold zone. The cold zone is essentially the safe zone on the outer perimeter. There's not zero risk of bullets flying or explosions or bad guys or whatnot, but it's a much safer area. Hot zone is, there's inside, that's where the active threat is, and that's where there actually are bullets flying. There's, immediate emergent danger. Warm zone is just right outside of the hot zone, where there's a high potential for it to become into the hot zone. So um, that's it. Questions? I'll open it up.